Hello, everyone. In this set of video lectures, we'll be talking about procedures on the heart and great vessels. And again, there's several different types of procedures that are covered in your text, but one that sometimes is misunderstood is the cardiac catheterization. And we can do cardiac caths for several different reasons: diagnostic, therapeutic, what have you. And table 12.1 in your text is very useful to kind of go over this. Let's take a look. And again, good point made here in the very first sentence. Technically, it's not a procedure. It's a percutaneous approach for either a diagnostic or a therapeutic procedure. And this could be a dilation in the case of an angioplasty or what have you. And again, these are located using table 4A02, and then you can see the approach, the function, and the device. There are other diagnostic procedures that are done for the circulatory cardiac system, and these include coronary angiograms. These can either be on the left side or the right side to reveal any valve lesions, any endocarditis. We can do coronary arteriograms to detect obstructions in the coronary arteries. We can do ventriculograms to measure the stroke volume and the ejection fraction in the case of heart failure patients. Imaging is used for coronary angiograms, arteriograms, and ventriculograms. Typically, these are with fluoroscopies. And the main term in the PCS index is fluoroscopy, with the subterms of artery and coronary. You can see this laid out in table 12.2. Let's take a look. And again, you can see here the first three characters, B21. And then for the coronary artery single, multiple, if there is a graft, so sometimes they'll refer to a native artery as opposed to a graft, and so on. So very important to read the documentation thoroughly under the fluoroscopy entries. And then moving away from the diagnostic procedures into the therapeutic, we do the PTCAs, the percutaneous transluminal coronary angioplasties. These basically open the vessels and may be followed by an insertion of one or more coronary stents. And these stents can be drug-eluting or not drug-eluting. The objective is to dilate the vessel. So the main term in the index is dilation with the subterm artery, coronary, or bypass graft. So sometimes when somebody has a CABG done, coronary artery bypass graft, that graft will become occluded. And this is described in table 12.3 in your text. Let's take a look. And you can see table 12.3. Note that it's 02, medical surgical, 2 being heart and great vessels, and 7, dilation. Now it's where it gets interesting. Can be all different types of things: coronary artery, 1 artery, 2 artery, 3 arteries, 4 or more, open, percutaneous, percutaneous endoscopic, and then where a lot of people go wrong is over here. with the device. It can be an intraluminal device, in other words, a stent that's drug-eluting. We can have 2 drug-eluting stents, 3, 4, or more. We can just have a stent that's not drug-eluting, and so on, as you can see here. Now we get into the bypass grafts, and we can kind of separate these generally into 2 buckets, if you will. We can use the aortocoronary, in other words, it's bringing blood directly from the aorta past the obstruction into the coronary artery using a segment of the saphenous vein located in the lower leg. Or we can use the internal mammary artery, right? And basically we loosen the distal, meaning farther end, to bring blood from the subclavian artery into the occluded coronary artery past the occlusion. And the root operation in this is a bypass, and the body part value is the coronary artery. If a saphenous vein is used, it's considered a device, even though it is a saphenous vein typically from the patient if they have good veins. So in this case, it's an autologous vein tissue. If an internal mammary artery is used, however, it is not considered a device. Why? Because it's still attached on one end. And again, you may want to spend some time reviewing table 12.4 on this. Let's take a look at table 12.4. And again, as discussed, medical surgical 0, 2, of course, for heart and great vessels, and the operation is a bypass. And then this is where we have to read the op note carefully. It can be 1 artery, which would be body part 0. It could be 2 arteries, 2 coronary arteries, 1, and so on. The approach, believe it or not, they can do percutaneous, right? Although many times these are done open. And then in terms of the tissue, if it's a saphenous vein, autologous venous tissue, sometimes they use synthetic grafts, what have you. And then the qualifiers as discussed. Another thing that is totally different for those of us who have been in the field long enough to remember ICD-9 was the cardiac pacemakers. There are actually 3 components to them. The pulse generator, which basically is the battery, if you will, the pacing lead, so the lead being the part that gives the electricity to the electrode, and then the electrode itself, that's the part that comes in contact with the heart. Important to read the documentation as to whether it's a single chamber that goes into the right atrium, right ventricle, or it could be a dual chamber that goes into both the atrium and the ventricle. These also can be either rate responsive, meaning that they have the pacing rate determined by other variables that on the patient, or they can be a resynchronization pacemaker. So it basically performs the pacemaking itself. If you see a pacemaker, you should have more than one code. Figure 12.3 is a great example of this. This talks about a pacemaker, a dual chamber pacemaker that requires 3 codes. The 3 being the insertion of the lead into the right atrium, the lead going into the right ventricle, and then the implementation of the generator into the chest of the subcutaneous tissue. And the root operation for this will be insertion. Let's take a look at table 12.3. . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . And again, this diagram's kind of useful. You can see here the leads going in, right? And then the generator is typically placed in the chest. Here are the codes. So we have 02H6JZ, insertion of device in right atrium, J being for the cardiac lead. Pacemaker, we have 02HK3JZ, insertion of device into ventricle for the right ventricle. And then we have 0JH606Z, insertion of device, subcutaneous tissue and fascia, chest, the device being the pacemaker. Then we have the defibrillators, the ASCDs, and this is a pacemaker that treats patients with recurring dysrhythmias. And it is an electrical device with a pulse generator and 3 leads. The generator, like a pacemaker, is placed in the subcutaneous tissue of the chest, and 1 lead goes into the right ventricle, 1 into the right atrium, and the 3rd at the apical pericardium. And these procedures are coded similar to a pacemaker. The device value is different because it's a cardiac lead defibrillator. The root operation is the same. It is an insertion. And for both pacemakers and AICDs, you'll want to take a look at tables 02H and 0JH for the code construction. And that's all I have for you. We'll see you online. Bye now.